Hello, this is Adam, and today I'm going to be covering the second section of the PEDS unit for Pharmacology 2. This is going to cover a little bit about pregnancy and some of the complications that can happen to mothers during pregnancy that require some drug treatment, and we'll kind of go through the neonatal period and some of the conditions that neonates are predisposed to. So to start out, we will be talking about pregnancy and lactation. We'll mention a little bit about pregnancy categories and teratogenesis, and also how drugs can be transmitted during breastfeeding. So a little bit of history. We know now that the uterus kind of acts as a protective environment, but it's not 100% effective in all cases. And so actually the first kind of knowledge that we had about conditions that the mother contracts or exposures that the mother has leading to birth defects actually dates back to 1941, where they actually were able to discover that mothers who were contracting rubella were actually having babies that were developing cataracts. And so this is kind of the first time that people made that association that environmental factors on the mom can actually have downstream effects on the baby. Another case happened later on in 1948 with the introduction of DES, or diethylstilbestrol, and that was one where we actually did not discover the effects until much later, not until we actually saw the offspring develop certain cancers later on in life, and it was still very difficult to have figured out that the mother being exposed to this was leading to cancers happening sometimes decades later. But that link was eventually made, and so this is where it kind of provides a lot of the background on teratogenesis that we know now. I think a lot of people are familiar with the case of thalidomide. This is actually used as an anxiolytic back in the late 50s, early 60s. Mainly used overseas, such as in the UK. Fortunately, did not get a lot of use over here in the US, but what ended up happening was that these women who were utilizing thalidomide were actually having children with these birth defects, where basically the limbs were not forming correctly. So because of that, led to many of the laws regarding medications during pregnancy being passed. So once we saw that happen, U.S. lawmakers decided to put some steps into place to make sure that something like this didn't really happen in the future. So this is just a little bit of evidence regarding drug use by mothers during pregnancy. This is a WHO survey from back in 1991, and actually interviewed many women, around 15,000 from 22 countries, and they only were really including prescription medications. So obviously things like over-the-counter medications were probably not really accurately being captured in this study. What they actually found was that in regards to prescription meds, around 86% of these women took a medication during pregnancy. The average number of prescriptions was reported to be around 3. And what was interesting is that the number of different people who were prescribing these medications. So 73% were by the OB, but then 12% were prescribed by their primary care provider, some by the midwife, and then 10% by this kind of other category. So it's easy to see that especially if the providers are not either communicating with one another, or the patient is not adequately describing their medication history, it's very easy for things to either be easy to make make decisions on bad data, where basically a patient may already have a drug for condition Y, but then you didn't know that, and so you end up prescribing something else for that. So a lot of duplication can happen when you have multiple providers being involved here. So just a few definitions here. So the first one being teratogenesis. So this is obviously any significant postnatal change in the form or function of an offspring after prenatal exposure or treatment. So the mom takes a drug, and then something happens leading to, say, either cancer or malformed limbs or something like that in the baby. That would be teratogenesis. These can be congenital anomalies, so this can include those malformations and defects related to the change in actual function, or you can have these congenital malformations where this is more related to like structural changes that happen. And they typically will be interfering with the viability or the physical well-being of the offspring in these cases. So some examples, there's a lot of drugs out there that can cause teratogenesis. So these are going to be some of the more kind of high profile common ones that you would see and definitely want to avoid in your pregnant patients. So ACE inhibitors would be one of the big classes here. That would include angiotensin receptor blockers as well, but certainly the ACE inhibitors are teratogenic. Androgenic hormones can fall into this category, so things like testosterone have been shown to have negative effects on the fetus. Obviously, cigarette smoking we know has a negative impact on the babies. But some other things you might not think about would be things like warfarin or Coumadin, which is why it can be difficult, because as we'll see in a little bit, that pregnant mothers can actually be kind of hypercoagulable. So if you have a mother who has a clot, how do you treat them for that when your major oral anticoagulants are kind of taken out? We talked a little bit about isotretinoin during the dermatology section. That one is so teratogenic and the effects are so significant on the fetus that they actually instituted that REMS program. That's that risk evaluation management strategy, where basically they have a program called the iPledge program, and the providers, the pharmacists, and the patient all have to register with them in order to make sure that the proper testing is being done, proper pregnancy checks and things like that, before the patient can even be prescribed and be dispensed the drug. So again, these are all strategies that have been put in place to make sure that these drugs don't get, mothers don't get exposed to these drugs, especially without them even maybe knowing that they're pregnant in the first place. Some other drugs, including things like anticonvulsants. So phenytoin and valproic acid are both very commonly used anticonvulsants. So if you had a patient who has a history of seizures, now all of a sudden you're kind of stuck because a lot of the seizure medications they might have been on are now kind of off limits due to their teratogenic effects. So you can see where a lot of these can provide some kind of interesting therapeutic dilemmas in a lot of cases. Lithium as well, commonly used to treat bipolar disorder. So again, if you have your patient who's being well controlled on lithium, and now you have to take them off of that while they're pregnant, which is already kind of a big change in their lifestyle anyway, you can obviously see where that can lead to some big issues. So the ways that we determine whether or not something is teratogenic, it can come from a couple of different sources. One can be case reports. So if a mother is exposed to the drug and maybe she didn't know she was pregnant, they can use that data in a case report to describe any congenital changes that may have occurred. Another big thing that we can do is going to use epidemiological studies. So actually looking at a large number of women who may have been exposed to a drug to see if there are any trends. Obviously, case reports may find some like kind of the big, very common things, but the epidemiological studies are going to be better for kind of sussing out those things that are less common. So maybe things that are happening only 1 in 1,000 or 1 in a million, depending on the size of the study. And then one of the more common ways we have are going to be animal studies. And so obviously testing in mice and things like that is not 100% relatable to humans, but it can be pretty beneficial in determining kind of that relative toxicity to humans. So obviously if we know something very serious happens to animals, we obviously are not going to necessarily try it in humans just to see if it happens or not. So sometimes animal studies can be predictive, but again, they're not always going to be directly relatable to humans. And of course, the kind of the standard pharmaceutical industry disclaimer is that the safe use of this drug in pregnancy has not been established, because again, it's pretty difficult to do ethical studies in pregnant women where you give one group some of the drug and you give another group no drug and see how their babies turn out. Obviously, not going to be all that too easy to pass through the IRB. So basically, there's not a lot of studies out there to help us determine the exact safety profile of these drugs. So they basically say that only use the drug if the anticipated benefits outweigh the potential risk. So it kind of leaves the provider in a difficult spot if they really need to treat the patient, but there's not really a lot of good data out there to support whether a drug can be used or not. So looking at the stages of fetal development and where drugs can kind of interact with this, we see that the pre-implantation occurs within 0 to 14 days post-conception. And then you have this organogenesis phase occurring between 14 to 56 days post-conception. And this is really the most critical period where drug exposure can have very, very significant effects, either leading to fetal demise or any kind of congenital defects we might see later on. Typically then from the 57 days on through birth, this is all just more functional maturation of the baby, and so we see less kind of these catastrophic effects you would see with drugs during this period, but we will see where certain drugs are going to become more or less detrimental to the patient as time goes on. You'll see some drugs which will be, say category D or category X in the first trimester, where they might actually be safe to give in the second or third, and vice versa, where things are going to be, say category B during the first and second trimesters, and then they go over to category D. So things can change depending on the drug and what actual state of development the fetus is in. So looking at how drugs can actually cross the placental barrier, this is very similar to kind of the principles that we saw in GI absorption of drugs. So again, a lot of it goes back to the physiochemical properties of the drug. So obviously things that are more lipid soluble, things that are lipophilic, are going to have an easier time passing that biological membrane. Obviously things that are charged are going to have a more difficult time crossing that biological membrane. So things that are in an unionized state are going to have an easier time crossing the placenta. There are sometimes cases where a drug will be in an unionized state outside of the placenta, and once that transfer happens, the slight change in pH might actually lead to the drug becoming ionized, and in some ways it can be trapped there. So in that way, the drugs will actually become more concentrated within the placenta. You'll see this happen as well with breastfeeding and drugs transferring over into the breast milk. Molecular weight is also very important for determining how easy these drugs will be able to cross the placental membrane. So obviously things that are smaller molecular weight, and this is in Daltons, less than 500, pretty easily crosses, whereas when you start to get to larger molecules, especially things like larger antibiotics like vancomycin, they have pretty poor ability to cross that membrane just because the molecule is so big. Also, protein binding is going to help limit how much transfer to the placenta we have. So obviously if the drug has a higher percentage of protein binding, more of that drug will be bound up by the proteins within the serum, so they're not going to be able to cross over quite so easily because they're just stuck in the blood. So some of the other ways that the placenta can actually help to, say once a drug gets transferred over, how does the placenta get rid of that, and how does it, what kind of protective mechanisms does it have? And really there's two main ways that this is going to occur. So one of them has to do with placental function. So the fact that it's a semi-permeable membrane kind of limits a lot of the drugs that you're going to be able to get by. And again, that goes back to last slide, where things that are not lipophilic, things that have a very large size, are not going to be able to cross this barrier in the first place. Once something is in the placenta, though, there's actually some limited drug metabolism that can't occur there as well. So that's kind of another protective feature just within the placenta itself. The other thing that we see here is that drugs that are entering the fetus through the umbilical vein, you'll know from anatomy lessons that the umbilical vein is going to go straight, a lot of that blood is going to go straight to the fetal liver. Now, we mentioned in the last class that the fetal liver is not necessarily, doesn't really have all the enzymes in the quantity and quality that we'd see with an adult, but there is some metabolism that can still happen there. And so this can provide kind of a protective feature if the drugs are being metabolized prior to actually reaching the fetal circulation. So looking at the categories of pregnancy, and this is kind of going out of vogue, and I'll talk about that in just a moment, but the kind of the old school mentality and the old school way of determining pregnancy categories, they went by this lettered system where it's A, B, C, D, and X. Now, category A is going to be designated for drugs that have controlled studies in women, and these studies have failed to demonstrate risk in the fetus during the first trimester. So the risk for fetal harm is very remote. Now, obviously, not very many drugs are going to be able to get this categorization because, again, it's not really ethical to have studies of these pregnant women. So usually you'll see very few drugs get this A category, and that'll usually be older drugs where their use has just been very commonplace back in the olden days, before a lot of these laws were in place, and as such, they were able to use that data to give it kind of this A rating. Now, category B is going to be given to drugs that either have kind of one of two situations. So the first one being they have animal studies that do not indicate risk to the fetus, and there have been no controlled studies in human women. So say, okay, well, we don't really know what the effects are on women, but we have these animal studies that say there's no risk, or we have animal studies that do indicate risk, but we have enough information on human use, and that has failed to demonstrate risk. So you see here the level of confidence you have in category B drugs is less than in A, but still at least have some data to maybe support that this is not going to cause any kind of fetal harm. So you'll see a few more drugs that will get the category B status due to that data that they have. Now, category C is going to be the majority of drugs that you're going to see out there are going to have the C rating. And so basically what this means is they have animal studies that indicate risk, and we don't have any real adequate controlled human studies. And so you'll see that, this is kind of the shrug your shoulders kind of category, where we don't really know what the risk is. We know that there is no definite risk. If there was definite risk to human fetuses, we would have gotten a D or an X rating, but instead we say, well, we don't really know what would happen in humans. We don't think there's really going to be a big problem, but it's too difficult to say at this point. So you really have to use it only if the benefits outweigh the risk. So again, this is not super helpful to clinicians, and the reason why this rating system is kind of going out of vogue. Category D drugs are going to be ones that have positive evidence of fetal risk, but there may be certain situations in which the benefits outweigh the risk. So this is, for instance, if you had a drug that you needed to get the mom, otherwise mom is going to succumb to her illness. Obviously, if you have the mom die, the baby's not going to make it either, so there may be those kind of rare situations in which giving the drug, the benefit outweighs the risk. And then in category X, there is definite fetal risk, and the risk outweighs any benefit that the pregnant woman could potentially have. So that would be absolutely contraindicated. D is going to be mostly contraindicated, but X is for sure contraindicated use in pregnant women. So the way that this is going to be changing is that instead of simply giving a rating, which again most things would be getting a C rating, they're actually moving to making the evidence behind this much more clear. So in your newer drug references, when you look it up, you'll see the actual studies that show what type of risk or not risk, what exactly the findings were when they studied these drugs in these women or in these animals. And that way you can actually read the data and decide for yourself whether or not the benefit outweighs the risk. So again, this is kind of a newer thing. You'll see this moving forward, where a lot of these drugs will not be, new drugs will not be getting a designation on this pregnancy category, but you'll still be able to find, drugs that already have a category, you'll be able to still find that information. So in regards to transfer of drugs from the mother to the breast milk, we'll see that there's similar characteristics here as a placental transfer. So again, lipid solubility is going to be very important here. So things that are lipid soluble will have an easier time getting into the breast milk. Obviously, when the breast milk has a higher lipid content, so it's kind of hind milk, you'll be able to see that you'll have better partitioning of the drug into the milk. Charge, again, is going to be very important. Again, you can find that kind of charge, this kind of ion capturing that occurs where the pH of the breast milk is going to be a little different than that of the mother's serum. So when the drug crosses over into the breast milk, it becomes more ionized, in which case it is not able to cross back into the mom's serum, and this is trapped there in the breast milk. Again, molecular size and protein binding are going to have similar effects as we saw with the transfer from the mother to the placenta. So some additional factors that can be taken into account here. So the time since delivery. So what actually develops are these large gaps in the mammary alveolar cells. Now these are going to be closing within 2 weeks postpartum, but initially when those gaps are the largest directly after birth, it's easier for these drugs to cross over. So some things that might not cross at all, say a month from now, may have an easier time crossing right now due to these gaps. And again, another major determinant is going to be just the maternal concentration of drug. So this is one of those things where the higher the concentration is in the mom, these drugs are going to want to go from areas of high concentration to lower concentration. So the concentration is high, a lot of the drug is going to make it into the milk versus when the serum level is much lower. So this is one of those things where you can actually have strategically scheduled feedings, where that term kind of pump and dump comes from, to where a mom could be getting a dose of the drug and say for the next 6-12 hours, they would be, whatever breast milk they were able to pump would be discarded, and then they can utilize breast milk after that period in order to feed the baby. So I know a lot of times, especially alcohol is one of the big ones. Mom hasn't been able to drink for 9 months, and now she's able to have a drink. They can kind of strategically plan out when the breast milk is safe to use. They actually have strips. They actually dip it into the milk and tell what the alcohol content is to make sure it's safe for the baby. So kind of interesting things there. And then again, we mentioned the pH already of the breast milk, but again, it's going to be anywhere ranging from 6.35 to 7.67. So definitely not a little bit different than the range you would see, much broader range you would see with the serum pH. And so again, we can see trapping of drugs within the breast milk due to this pH change. So don't get scared off by this slide. I just wanted to use it as an illustration of how these drugs are able to be transferred over to the breast milk. So you see on the bottom part of the slide, this is kind of where we have this is the mom side. This is kind of where the blood flow is coming from, and then on the top part, this is where we see actual transfer into the breast milk itself. So lots of different ways that this is happening. Again, some of it is just through exocytosis. Some of this is going to be through actual protein transporters. You can see there, some of them will actually be going through paracellular pathways, so it can actually travel between the gaps. Again, this is one of those ones where you saw those gaps were being much larger in the first few weeks postpartum. So again, nothing really to memorize here, just realize that there are several mechanisms for which these drugs can transfer over into the breast milk. So actually looking at the physiological changes that are occurring to the mother while being pregnant. So lots of things are happening to the mom's body during this time period. So we see blood volume is actually increasing by around 30 to 40%. To go along with that, we also see that the renal blood flow is going to be going up by 30%, and their GFR can actually go up by 50%. This would make sense why they have to go to the bathroom so often, for sure. All this extra blood flow going to the kidneys, they're filtering out lots of things, so obviously going to the bathroom is going to be a pretty common thing. Looking at cardiac output, that's going to be increasing as well by around 30 to 35%. Generally see a slight rise in their heart rate. We're also going to be seeing a decrease in GI motility, so we'll see the constipation is going to be a big issue in a lot of mothers. We also notice there's just going to be this hypercoagulable state and the dreaded weight gain that comes along with being pregnant. So some of the conditions that are coming about from all of these different physiological changes that we can use to treat, or we can use medications to treat, are going to include nausea, vomiting. Especially in that first trimester, you see nausea and vomiting being very common, heartburn, constipation, hemorrhoids, and then rarely we can see some coagulation disorders that occur secondary to this kind of hypercoagulable state that the mom is experiencing. So going into the different complications that can occur, obviously you're going to get this in more detail in other classes, but just to kind of briefly describe it, so there's pregnancy-induced hypertension. Again, just having straight gestational hypertension would just be defined as having a BP over 140 over 90, but this is without the absence of proteinuria after 20 weeks of gestation. As the blood pressure continues to rise, you're going to see that there's going to be more proteinuria that's going to be happening here. So when you have mild preeclampsia, so you have greater than or equal to 300 milligrams of protein in the urine in a 24-hour period. And this is somewhat common. Anywhere between 6 to 8% of pregnancies can encounter mild preeclampsia. Severe preeclampsia, again, we're going to be seeing, again, elevated blood pressure, pretty significantly so, and then also this increase in proteinuria that occurs other than the urine. And they can also be starting to have some of the actual signs and symptoms of significant hypertension. So they can be complaining of severe headache, start to have things like visual disturbances and epigastric pain. And then actual full-blown eclampsia occurs once they start to have these tonic-clonic seizures that happen during this significant hypertension that happens here. To go along with that, we can also see that some women will experience gestational diabetes. So again, this is going to be any degree of glucose intolerance that's going to be happening during pregnancy. So again, this can be fairly common, affects up to 7% of all pregnancies. And typically the women are going to be screened at 24 to 28 weeks gestation, where they can do one of those oral glucose tolerance tests to determine if they have any degree of glucose or insulin resistance, glucose impairment, sort of thing. Again, this usually will resolve after delivery, but some women that develop this are going to be at higher risk for developing type 2 diabetes later on in life. So risk factors for developing gestational diabetes will include age greater than 25 years, if the patient was overweight prior to the pregnancy, ethnic groups that have a higher incidence of diabetes baseline will have a higher risk for developing gestational diabetes. If you have any first-degree relatives with known diabetes, history of abnormal glucose tests, or history of a poor obstetric outcome, usually this is related to this gestational diabetes previously. Also, another thing we can see is going to be postpartum depression, and so kind of termed the postpartum blues. You can see approximately 10% of childbearing women will actually experience true postpartum depression, generally within the first month after childbirth. Fortunately, this is something that's becoming more well recognized, and they're starting to see this increased desire to treat by physicians. But especially during that first period of time directly after birth, obviously we're going to see that certain medications are going to be crossing into the breast milk, which can lead to potentially levels of antidepressants in the baby itself. So there's ongoing research to determine what kind of effects this is going to have long term. Again, some of the signs and symptoms you're going to see during postpartum depression, obviously depressed mood, lack of interest, kind of feeling of worthlessness. You'll see that a lot of these things like loss of energy and weight loss, that could just be assumed to be normal sequelae of childbirth, but it may actually be signs of this postpartum depression. So all things to kind of look through or look for when kind of interviewing your moms directly after birth. Regarding treatment of some of these acute conditions, so for nausea and vomiting, obviously if there are any kind of dietary changes that occur or that can help to kind of alleviate some of this, so pregnant women oftentimes will have kind of altered olfactory sensations, so certain things will end up triggering them. So if all of a sudden the smell of a certain type of food triggers them, obviously you want to try to avoid that food. As far as medication goes, it can help to treat nausea and vomiting associated with pregnancy. The two medications that have A ratings, A pregnancy category that are commonly used includes pyridoxine. Again, this is just vitamin B6, so normal water-soluble vitamin. They can take this 10 to 25 milligrams, anywhere between 3 and 4 times a day. Again, this is a pretty harmless vitamin. It does pass easily into the breast milk, but again, there's no expected harm to the infant. With doxylamine, this is going to be a H1 receptor antagonist or histamine 1 receptor antagonist. So this falls into the same category as your diphenhydramine, your meclizine, things like that that we've talked about previously. Again, not a lot of data on this one on lactation. It probably does pass into the breast milk. So the big things you'd want to look for here are going to be the similar side effects you would expect to see with any first generation antihistamines. So that would include things like sedation, kind of dried mucous membranes, things like that you would normally expect to see to concur as well. Again, some of the moms who have difficulty sleeping during pregnancy, this might actually be a benefit as well. Doxylamine, the over-the-counter version is just Unisom, so it's marketed for sleep anyway. So this might actually can help with this. There is a newer prescription product available. It's called Diclegis, which is just a combination product of doxylamine and pyridoxine. This is a delayed release product, so maybe you get away with taking it less often, but it is going to be much more expensive than the mom just going to Walgreens and buying doxylamine and pyridoxine separately. But for some women, this is the preferred drug. Other agents that we can utilize to help treat nausea vomiting during pregnancy would include meclizine. Again, this is oftentimes used to treat things like vertigo, but it's another over-the-counter agent. Again, this is an older drug, has a pregnancy category rating of B. Again, this is an antihistamine, so you'd expect the similar side effects. So kind of the sedation being the biggest one. They can also see those kind of dry mucous membranes, potentially constipation, things like that associated with the kind of the antimuscarinic effects these drugs are having. Promethazine is another drug which has some antihistaminic actions here. Phenergan is the brand name for this drug. This is going to be a prescription product. Some of the nice things with this one is it does come in a rectal formulation, so if the mom's having very significant nausea and vomiting, the rectal formulation is available. This one we don't have as much data on to support a or B pregnancy category, so again this one gets a C, but use has been frequent enough that it's probably fine for the fetal development. Generally, though, utilizing one of the first generation antihistamines like doxylamine is preferred, but if those continue to fail, then something like promethazine can be utilized. Finally, the newer class of agents, and we'll talk more about these in the GI section later on in the class, but another group of medications that can be utilized to treat nausea and vomiting. These are actually very, very effective. These are the 5-HT3 antagonists, and so 5-HT3 is just a specific subtype of serotonin receptor. So 5-HT is just another way for saying serotonin, and these drugs will actually block those specific serotonin receptors, which get activated when there's a trigger for nausea or vomiting. So again, the drugs that fall in this category include ondansetron or Zofran, granisetron or Kytril, and dolasetron. Usually ondansetron is probably one of the more common ones that you'll see being utilized. They used to be more expensive, and they still are more expensive than your cheaper over-the-counter products, but they tend to be more effective. So you can try utilizing first-generation antihistamines first, and then move on down to something like one of these 5-HT3 antagonists. Fortunately, though, there's enough data to support having a B rating, so this is okay to use for the fetus. Looking at heartburn, some things we can do to help limit this would be including eating more small meals throughout the day, so just eating more frequently in smaller amounts. Generally, antacids can be utilized. Again, most of these antacids we'll talk more about in the GI section, but these are just things like calcium carbonate. These are things like magnesium containing antacids, and so generally they're pretty safe because again they're just electrolytes. In general, though, we'd want to avoid utilizing sodium containing products or use low sodium containing products, because again if the mom has too much of a sodium overload, this can cause fluid retention, which they might be experiencing anyway, but could potentially worsen their hypertension as well. And then another agent utilized for heartburn can include famotidine. Famotidine being an H2 receptor antagonist, this blocks the histamine 2 receptors. Another agent that's similar to this would be something like ranitidine or Zantac, but famotidine actually has a B rating. This one is preferred because it actually does not concentrate as much in the breast milk like ranitidine does. Ranitidine is one of those drugs that tends to get ion trapped within the breast milk, so this is why famotidine is kind of preferred. It doesn't usually do that as much. Cimetidine, another brand name for that one is Tagamet. That one is not preferred, but mainly due to the fact that it has a lot of CYP drug interactions. It inhibits CYP3A4, so it can actually interact with a lot of other drugs, and so cimetidine is generally not recommended for use for heartburn. As far as treatment for constipation goes, generally want to increase the amount of fiber the patient's getting in the diet. So a lot of the fiber products available out there, so things like psyllium husk and things like that, can be very useful. Even some moderate exercise can kind of help with constipation. And what we'll see drug-wise is that bulk laxatives are going to be our drug of choice, mainly because these things are not going to be absorbed. So this would include things like polyethylene glycol-based products, so like your Miralax. Those basically work to provide a lot of bulk in the GI tract, and it's able to kind of pull a lot of liquid in with that, a lot of water. And so by doing that, it basically increases the bulk. The GI tract feels that and says, okay, we need to evacuate this stuff. So bulk laxatives are generally going to be drugs of choice because, again, they're not being absorbed. We can utilize certain stool softeners as well, so something like Docusate, which helps as to work as kind of like an emollient for the stool to help it kind of ease its passage, can be utilized as well. Generally, though, you would want to avoid products like mineral oil. This is generally because mineral oil is very lipophilic, and it can actually lead to decreased absorption of certain fat-soluble vitamins. So these would be like your vitamins A, D, E, and K. You might see kind of chronic, but with chronic use of mineral oil, you'd see less absorption of these vitamins. And then for treatment of diarrhea, we'd obviously want to be using things like stool bulking agents. So again, fiber can be very useful here for doing that. And then the drug of choice for if these were not working, would be loperamide. Loperamide is an opioid type drug that fortunately does not cross the blood-brain barrier. So loperamide, while it does activate some of the mu receptors in the GI tract to help slow down peristalsis, it does not cross the blood-brain barrier. So that's why we don't really see any analgesic effects or any of those kind of euphoric effects you see with other opioids. And this one is compatible with breastfeeding as well. As far as treatment for hemorrhoids goes, obviously if you avoid constipation, your chances of getting hemorrhoids are going to be reduced. In general, though, we want to use external topical products because we can see with internal products some systemic absorption. So again, avoiding things like local anesthetics, because again those can have systemic absorption. Generally we can focus more on using things like preparation H, which generally has a kind of vasoconstrictor in it, something like a pramoxine or phenylephrine can be utilized for that, and then tox wipes as well are okay to use, along with sitz baths. So again, try to avoid using internal products as they can be absorbed. If the mother determines, or the mother comes down with a UTI, again, we always do want to treat these if they're asymptomatic. We worry about bacterial translocation to the fetus. So some of the drugs that we can utilize for this would include things like nitrofurantoin, macrobid would be a brand name for this drug. You can utilize it twice a day. So it does have a category B. Amoxicillin would be another good option as well. And then potentially you can get away with utilizing usually like a first or second generation cephalosporin. So something like a cephalexin might be a good option here as well. Again, this is going to be one of those situations where depending on what your antibiogram looks like, depending on what the kind of the resistant rate are in the community, this might guide you to picking one over another. So for instance, if you know that your cephalexin resistance is pretty high, then it might make more sense to use something like nitrofurantoin. And again, all of these are going to be compatible with breastfeeding. So for cold symptoms, again, we want to provide kind of environmental support, so try to utilize non-pharmacological therapies as much as possible, make sure you're getting lots of fluids. But again, you'll see that as far as medications go to treat kind of common cold symptoms, we'll see that antihistamines are going to be safe to use. So things like doxylamine and diphenhydramine can be utilized, especially if the patient's having a lot of nasal drainage or postnasal drip and things like that. Help kind of dry things out a bit. Dextromethorphan or Delsym is a good antitussive agent. Generally, though, we try to avoid this, especially in the first trimester. Again, we just don't have enough good data to say whether or not there is risk associated with the fetus. So try to avoid using dextromethorphan if possible. And then pseudoephedrine as well. This drug, again, utilized as a vasoconstrictor to kind of deal with nasal stuffiness. Again, try to avoid this one as well because of the fact that this might actually be worsening the mother's hypertension. As a vasoconstrictor, it does the same thing to increase your blood pressure. So that may be avoided when possible. If the mother is experiencing pain, some drugs that we can utilize during pregnancy, acetaminophen or Tylenol is always going to be our drug of choice here. It is a Category B drug. It's compatible with breastfeeding. We've talked about acetaminophen before, but it works to inhibit cyclooxygenase 3, especially up in the CNS. So utilized for analgesia as an antipyretic. This is kind of your go-to drug for pregnant patients. NSAIDs, on the other hand, though, are a little bit trickier. They're actually going to be a Category B during the first and second trimester, but during the third trimester, they actually are going to be a Category D. A lot of this is related to the fact that for the fetus, their ductus arteriosus is open, and this is actually closed or is being kept open by prostaglandins. So by giving an NSAID that actually inhibits production of those prostaglandins, you can actually end up causing a premature closure of the ductus arteriosus and lead to some perfusion issues with the fetus. So that's why it's avoided. It's a Category D in the third trimester. Morphine is actually okay to use as Category B during the first and second trimesters for short periods of time. Now this drug does transfer to the placenta. You can see some issues, especially if there are prolonged use or high doses at term. You can actually see some pretty significant amounts of the drug going to the baby. So you can actually see some of the similar effects you would see. So sedation, respiratory depression can occur as the blood levels in the fetus rises. This one is, will cross into the breast milk. Can definitely measure levels in the baby after being exposed, but in some cases it may be necessary to treat the mom. So this might be one of those ones where you do a little bit more strategic use of kind of the pumping and dump method for the breast milk. Then as far as treatment for hypertension during pregnancy, so the patients who are already having chronic hypertension prior to being pregnant are generally going to be the ones who are at risk for preeclampsia. Drug of choice during pregnancy is going to be a drug called methyldopa. This is a Category B drug. It's a pretty old school drug, and interestingly enough, it works by kind of looking similar to how some of our endogenous catecholamines look. So it looks kind of similar to things like dopamine and norepinephrine. And what this drug does is actually activate a specific subset of alpha receptors, so alpha-2 receptors. Activates this up in the CNS, and when those receptors are activated, it signals the neuron to stop firing more of these catecholamines from being released. So by activating that, by being kind of like a false neurotransmitter, it actually inhibits further release of catecholamines, which will lead to decreased heart rate and blood pressure downstream. This is kind of similar to how a drug like clonidine would work, which we've mentioned previously. Labetalol would be kind of a second string drug that can be utilized. As you guys remember, this is a kind of a mixed action beta blocker. Will block beta 1 and 2 receptors, but also have some anti-alpha activity as well. This one will be a C class in the first trimester, and then D in the second and third trimester. So again, probably not something we want to use. Try to stick with methyldopa when possible. Obviously, ACE inhibitors have known teratogenesis, so we want to avoid using those. And we'll see that actually when the mom is breastfeeding, that there's lots of agents that are compatible with this. So really just kind of check on your drug references prior to prescribing. As far as treatment for some of the chronic conditions, so diabetes, a lot of the anti-diabetic medications out there either don't have enough data or in pregnant women or are detrimental to the fetus. So insulin is actually going to be the drug of choice during pregnancy and lactation. So while it's not ideal to have the patient have to inject themselves multiple times a day, it does not cross a placenta or into the breast milk. Again, insulin is going to be a little bit larger protein, and as such, it's not going to be able to cross those membranes very easily. As far as treatment for postpartum depression, obviously we'll talk more about this in the behavioral section, coming up a little bit later in the class. But the drug of choice here are going to be our selective serotonin reuptake inhibitors. We'll talk about those at length in a few classes. But essentially, what these agents are doing is working when serotonin is released from the neuron. Oftentimes, they're being recycled by being taken back up into the neuron through certain transporters. These are these reuptake transporters. What these drugs actually do are come in and bind up those reuptake transporters, inhibit those, and so it actually increases the synaptic levels of serotonin. That's not really the full story for the mechanism, but that's kind of good enough for right now. These are very effective agents utilized for treatment of depression, and they're pretty well studied. And they lack a lot of the side effects we'll see with a lot of older agents. And so as time goes on, as we have a better understanding of depression, have a better way to recognize it, there's a lot more data coming out regarding women being exposed to antidepressants. And there are some concerns about fetal exposure leading to things like depression later on in life. But again, a lot of those kind of long-term studies have yet to be completed due to just the amount of time it takes for these kids to grow up. So some issues that we can see that we know of, especially when infants are being exposed to SSRIs intrapartum, is you can actually end up seeing withdrawal effects that can occur after birth. So the mom is taking her say her Prozac during pregnancy and the baby's born, and all of a sudden the baby's not getting that drug anymore, and so there are some withdrawal effects that can occur with that, including agitation, hypertension, things like that. So again, we're still trying to figure out the long-term developmental effects after exposure, and the breast milk exposure effects are unknown as well. Just as a point of reference, some of the example agents that fall into this SSRI category include citalopram or Celexa, escitalopram, which is the left-handed form of citalopram or Lexapro, paroxetine, Paxil, and fluoxetine or Prozac. So those are some of the more common SSRIs that you'll see. As a backup, you could potentially use a tricyclic antidepressant. These are kind of old school antidepressants. They have a lot more side effects associated with them, and so they're utilized as kind of second line agents to the SSRIs. Currently, there's been no adverse effects reported on the fetus, and some agents that would fall into this category include things like amitriptyline, nortriptyline, and desipramine. Again, we'll talk more about this when we get to the clinical behavioral section. So again, general guidelines for using medications in pregnant women: you would try to avoid use of medication as much as possible unless it's absolutely necessary. Again, try to manage some minor complaints with non-drug therapy whenever possible, but do not overlook the patient's welfare. Again, we've got to treat the patient first, and try to do right by them as well. So again, always weigh that risk versus the benefit, and try to have that good conversation and educate the patient on why, what those risks and benefits really are. Again, when the medication is necessary, always check the most up-to-date literature that's possible regarding fetal effects. Again, there's potentially always something new coming out. Try to keep the doses well within the therapeutic guidelines whenever possible, and we try to use drugs for the shortest period of time that we can, and also try to monitor closely throughout therapy. One other drug that may be utilized prior to pregnancy. All women capable of becoming pregnant should be consuming folic acid. 400 micrograms a day is recommended, and this is to help prevent neural tube defects. It's estimated that supplementation can prevent greater than 50% of cases of all neural tube defects. So again, this is something that all women of childbearing age should be taking in order to help prevent this, because again, pregnancy can potentially happen unplanned, and so this is something to help prevent those neural tube defects from occurring in the first place. But for women who have actually given birth to an infant with a neural tube defect, they are actually recommended to consume around 4 milligrams, so a much higher dose of folic acid, and try to begin at least 1 month prior to conception. Unfortunately, though, the actual rate of people following this is fairly low, but again, just to kind of put that out there, that should be something to be considered. Alright, next we're going to be talking about care for the baby once they are born, especially in the neonatal intensive care unit. Okay, so we've already started, last class we talked about the different terms used for a child at different ages. And again, we're really going to be focusing on the neonatal period, so that first 28 to 30 days after birth, when they are potentially more prone to some of these specific conditions that we're going to be talking about today. So just again, some few terms to talk about. So again, if a child's small for gestational age, based on their weight and their age, they would be less than the 10th percentile. If they were large for gestational age, they would be greater than 90th percentile. And then actually looking at the different categories of low birth weight. So you have low birth weights less than 2,500 grams, very low birth weight, which is less than 1,500 grams, and then extremely low birth weight, which would be less than 1,000 grams. So it's pretty incredible that we've seen some NICU kiddos who will be only 600 grams. Really not much to speak of, but some of those X24 weekers and whatnot can be really, really tiny. So again, dosing, making sure you're getting an accurate dose to your patient can be very difficult, depending on formulations and concentrations and things like that. Again, just kind of looking at fetal development, we can see here that obviously these early stages are going to be so important during this organogenesis phase for maternal drug exposure and things like that, and those effects it can have on the fetus. In general, the later on we're getting, it's mostly just development and maturation of the tissues, and then in general we will see birth, the full term between that kind of 38 to 42 weeks or so. So the first thing that we will discuss regarding these kind of neonatal conditions will be this term of neonatal sepsis. So in general, this will be an invasive bacterial infection that's occurring within the first 90 days of life. It's not extremely common, but it can occur between 0.5 and 8 out of 1,000 births that occur. And typically you're going to see higher rates of this occurring in those low birth weight infants. There are kind of three main types or three main etiologies of neonatal sepsis. So it can happen in the intrauterine period. We can see perinatal acquisition actually during delivery of the baby, and then potentially acquisition of the infection during the hospital stay. Some of the risk factors we'll see for neonatal sepsis will include things like gestation that's less than 37 weeks, so again, premature children are going to be more at risk. If the mother has a premature rupture of the membranes, if they have an extended period of time where the membrane has been ruptured, so greater than 18 hours, chorioamnionitis, temperature greater than 100.4 during labor, if they have sustained intrapartum fetal tachycardia, and then also if the mom has a prior delivery of an infant with group B strep. Group B streptococcus is what GBS stands for. So some of the signs and symptoms, again, when you have a small child who's just born, it can be sometimes difficult to diagnose this. Oftentimes the signs and symptoms are going to be kind of non-specific and non-localizing. So oftentimes you'll see treatment based on kind of going with a more conservative mindset, because again, this is not one of those things you want to miss, because it can be seriously detrimental to the child, potentially even deadly in a lot of cases. So again, if you're seeing things like diminished spontaneous activity, if they're having a lot of temperature instability, so either hypo or hyperthermia, any kind of respiratory distress or neurological findings, especially GI things where you have like vomiting, diarrhea, abdominal distension, but again, even seeing those things like poor feeding and irritability, is it just a normal course for the baby, or is this maybe a sign of sepsis starting in? So this is why one of those things where oftentimes patients will be treated empirically just to rule out infection, because again, the effects can be so devastating. So looking at sepsis, we'll see that the treatment differs a little bit versus based on whether or not we're having early versus late sepsis. So early onset would be sepsis that has onset between birth and day 6 of life. On the late onset side, this would be onset that's happening after this period, so 7 to 89 days of age, right? So this is going to be during that first 3-month period. Even though technically they're outside of that neonatal period, greater than 30 days, they're considered infant at that point. This time period is still a potential where that bacterial infection can occur during that neonatal period. Looking at the organisms that are potentially causative agents here, we can see that especially during the early onset, we're more worried about bacteria that can be caught from the mother, especially during normal vaginal birth. So obviously group B strep is going to be one of the big causes here. And again, the child's immune system is not really going to be up to par as we would see with an older child. So this is why even something like group B strep can be very prevalent here. We can also see other things like E. coli and also listeria. And listeria, this is the reason why the moms have the recommendation not to eat things like cold cut meats, hot dogs, unpasteurized cheeses and things like that, because they can contain listeria. Even if the mom may not actually manifest any disease from this, can potentially pass it on to the child. Looking at organisms for late onset sepsis, you can see again group B strep is represented here, E. coli, and then we actually see staphylococci being a potential organism here along with Candida. And again, some of these things are going to be kind of like normal skin flora that we can see causing disease. The manifestations for early onset sepsis are typically going to be bacteremia. And then with late onset, it can either present as bacteremia or potentially could be a focal infection that maybe has spread to kind of disseminate itself to more systemic disease. So looking at treatment for early onset sepsis, we'll see that empiric therapy is going to generally include ampicillin. It's going to be given 200 to 300 milligrams per kilogram per day, divided generally between every 6 to 8 hours. And again, the dosing I'm not going to expect you to remember, but definitely the drug choices could be options for testing material. So we'd use ampicillin, and that's really going to be our drug treatment for listeria specifically. So ampicillin is always going to be the drug of choice for listeria specifically. And then also gentamicin. And gentamicin is going to be useful for covering a lot of the gram-negative bugs. Ampicillin will still have some coverage for like the group B strep, but we specifically have ampicillin here for the listeria risk. But using these two drugs, you have good coverage of most of the causative organisms for early onset sepsis. So this will be our empiric therapy of choice. Typically the duration of treatment will be around 10 days. Some of the factors that are predictive of death or serious sequelae for late onset sepsis are going to include things like low birth weight, if they've had symptoms for a longer period of time, so over 24 hours, they're experiencing leukopenia or neutropenia, and then if they start to have any kind of issues like seizures or focal neurologic deficits, which may be could be signs of things like CNS involvement with the disease, and then also they have requirement for mechanical ventilatory support. So if they're having enough respiratory distress or not able to support their own airway any longer. Looking at empiric therapy for late onset sepsis, we'll see that the choices is a little bit different here. So here for empiric therapy, we'll be utilizing ampicillin or vancomycin. So the vancomycin is going to provide a little bit better gram-positive coverage, so especially if you were concerned with, say, MRSA or methicillin-resistant Staph aureus, vancomycin is going to be your better option here. And then you would use that plus either gentamicin or cefotaxime. Cefotaxime being a third-generation cephalosporin, this is going to have broader coverage than you would see with something like a first or second-generation cephalosporin. So oftentimes I will see, especially for babies that are coming into the emergency department, so say, mom had the child goes home, child gets sick, and then brings them back into the emergency department. This is the case I oftentimes will see late onset sepsis being treated, and they will start off generally with ampicillin and cefotaxime. That's what I see most commonly being done. Again, the benefit of utilizing cefotaxime is that you don't have to worry about issues of therapeutic drug monitoring like you do with gentamicin. It's a little bit wider therapeutic index. So that's oftentimes what you'll see. Oftentimes what you'll see from that standpoint, and still getting the coverage that you need to treat that particular group of organisms that occur with late onset sepsis. Now, with the duration of treatment, you're going to see here that for specifically just bacteremia, 10 days of treatment is going to be sufficient for that infection. But if you're going to have involvement of the CNS and have a meningitis, you have to treat for a longer period of time. Oftentimes, these antibiotics have a tougher time crossing into the CNS, So because of that, they need to be treated for a longer period of time to make sure they really eradicate that infection. Now, as far as maternal prevention of group B strep sepsis, all pregnant women should be screened between 35 to 37 weeks of gestation. Now, if they have a group B strep isolated from the urine, or they've been identified as a carrier, then you would want to give intrapartum antibiotics. And so you'll see this IA being the abbreviation here. Now, if you had a mom who has an unknown group B strep status, or if they have any of the following risk factors, then you would also want to give these intrapartum antibiotics. So they were gestation less than 37 weeks, if they have prolonged rupture of the membranes, or if they have a temperature greater than 100.4. So the antibiotics that would be recommended for prevention of group B strep for the mom would be generally penicillin is our go-to drug for this one. So we can utilize a IV loading dose. So again, that helps to get us to a steady state level much more quickly. So we give 5 million units and then followed up by 2.5 million units IV every 4 hours until the delivery. The alternative could potentially be ampicillin. Again, ampicillin is going to have good coverage against that group B strep. So again, this one you'll give a 2-gram loading dose followed by 1 gram every 4 hours. And then potentially if you had like a penicillin allergy that was really significant, you could utilize either a cephalosporin, because again, remember that the actual cross-reactivity of true penicillin allergies to cephalosporins is less than 1%. Alternatively, you could utilize something like clindamycin or vancomycin. Again, these are going to be more specifically covering gram-positive bugs, the clindamycin and vancomycin, but these can be utilized and that will definitely cover your group B strep. So again, looking at the actual infant once they're born, if they are ill-appearing, then you'd want to do the full diagnostic evaluation. So again, you're going to be getting things like CBC with deferentials, you're going to be getting your blood cultures, and also your lumbar puncture and culture here. Obviously, you would want to do your cultures prior to the start of antibiotics, especially if this does not delay the start of antibiotics. And so in general, because again this would be an early onset sepsis, you would want to start empiric treatment with ampicillin and gentamicin. Again, the ampicillin is going to be helpful in covering that listeria that we're worried about that potentially mom may spread to the kid. So you can kind of use this stepwise approach to deciding how to handle the healthy appearing infant. Obviously the sick looking ones, you're going to treat them until proven otherwise, those cultures come back negative. But for the healthy appearing kids, there are some cases in which, even though they're not manifesting symptoms, you would still want to treat empirically with antibiotics, just because you'd want to, they're either a high enough risk or they're kind of a more sensitive to the effects. So if they actually did have an infection, they could be pretty significantly affected by it. So looking at it as a stepwise approach, if you had a patient who had, say, gestation less than 35 weeks, and intrapartum antibiotics were started less than 4 hours prior to the delivery, then at this point you would want to go ahead and get all of your labs, do your LP, blood cultures, and you would start empiric treatment with antibiotics. So again, less than 35 weeks is premature, and the mom did not have antibiotics at least 4 hours prior to delivery, then you would go ahead and treat. Now, on the other hand, if you had a kid who was less than 35 weeks gestational age, and the mom did have intrapartum antibiotics greater than 4 hours prior to delivery, then at this point you would actually just go ahead and get your labs, do your LPs, but you would actually just observe the patient, not use any antibiotics for 48 hours. And once those cultures come back negative, then you don't really need to worry about it. Obviously, if the kid gets sick in the meantime, or one of those cultures comes back positive, then you would need to consider treating at that point. Now, for the kid who's not premature, so greater than 35 weeks, if the kid is healthy appearing and the mom did get antibiotics appropriately, then you actually don't need to do any further observation, but you would still observe for about 48 hours or so. If the child did not, or the mom did not get antibiotics for an appropriate period of time, then that would be another case we'd actually want to observe without antibiotics as well. So again, all depends on kind of how premature the child was, and then whether or not the mom was treated with antibiotics appropriately to kind of dictate whether or not you're going to start those empiric antibiotics. And this is specifically for the healthy appearing children. Another thing to be concerned about would be neonatal herpes, and again, this is going to be caused either by herpes simplex 1, which is responsible for about 20%, or HS2, which is more responsible for about 80% of these cases. The general thing here is that it's usually transmitted during vaginal delivery with an infected mother. In one of these cases, in this kind of case, a C-section would be the kind of preferred route in order to avoid transmission here. Obviously, looking at the baby, the signs and symptoms that would present themselves would be things like skin lesions. Again, they're having things like temperature instability, and seizures can definitely be a bad sign of CNS involvement and potentially apnea as well. Looking at localized versus disseminated disease, with the localized disease, you'll generally only see things like skin, eye, or mouth involvement, but you generally are not going to see a lot of CNS or organ disease associated with the localized disease. Once you start to get more disseminated, that's where you start to worry about things like viral meningitis and encephalitis. So when you start to see those CNS findings, CSF pleocytosis, and elevated protein concentrations, this is where you're going to start to see more of a disseminated disease type picture. As far as treatment goes, the indications that we'd want to treat would be at the first sign of neonatal disease, especially if you knew the mom, or if you knew the baby had been exposed due to the mom, or especially if they've been exposed to an active lesion. The drug of choice here is going to be acyclovir. We know this is an antiviral agent that actually works to prevent replication of viral DNA. This one you start up 20 milligrams per kilo per dose and give it every 8 hours. The duration here is going to be for 14 days for kind of localized disease, but it's going to be longer for disseminated or CNS infections because, again, the virus is going to be in a more kind of a protected area, being in the CNS, and we want to really make sure that we're treating long enough to really eradicate that infection. Another potential complication that can occur with neonates is this respiratory distress syndrome. Oftentimes this is going to be seen to occur when the lung anatomy and physiology is kind of immature. So obviously this is going to be something that occurs more with premature infants. Oftentimes it's going to be related to a lack of pulmonary surfactant, and we know that surfactant is really necessary to help kind of decrease that surface tension between the alveoli and air, and without having that we start to see the alveolar collapsing occur, which is what leads to a lot of this respiratory distress. So what you end up seeing when this occurs is you're going to have atelectasis, you're going to have increased VQ mismatch here, and which can lead to lung injury. Surfactant production typically starts to occur around 32 weeks gestational age and is generally matured by around 36 weeks. So obviously if you have a kid who's born before this period, they are going to be more likely to have issues with not enough surfactant, especially when you have those, some of those really premature kids like the X24 weekers and whatnot. They're really going to be a higher risk for developing this. Some things that can actually lead to increased amount of surfactant. If you were to give the mom antenatal steroids, and this would begin around 48 hours prior to the birth, betamethasone and dexamethasone could be options here to help increase surfactant production. Also, other factors can be things like prolonged rupture of the membranes or maternal hypertension. For whatever reason, it tends to increase surfactant levels in the babies. So again, our risk factors, we'll see that prematurity is going to be one of the biggest ones. The most common in neonates that are going to be less than 1,200 grams or less than 30 weeks gestational age. For whatever reason, males tend to be affected more than females, so about a 2-to-1 ratio. If the mother had a history of diabetes, if it was a C-section or there's rapid labor, and then also if there's cases of multiple pregnancy, so if you have twins or triplets, hypoxia, and then if there's a history of siblings with respiratory distress syndrome, they would also be at risk as well. So some of the signs and symptoms we'll see when this is occurring. Again, you can see that in the picture here you have kind of on the left side alveoli with surfactant, how the the alveoli are able to stay nice and open, whereas on the other hand, without the surfactant, they just kind of tend to collapse in on themselves. But the signs and symptoms that you would be seeing here would be things like rapid, labored, grunting respirations, atelectasis, obviously, especially on chest X-ray, tachypnea, pallor, cyanosis, all these things associated with this respiratory distress syndrome. And again, extremely low birth weight neonates may actually be unable to initiate or sustain respiration. So again, this kind of things will be pretty apparent when it occurs. So prophylaxis, kind of two things we can do: either prophylax or treat for respiratory distress syndrome. Typically, we will give prophylaxis up to 30 weeks gestational age. So again, at the time of birth, surfactant will be given at this time. So the prognosis with treatment is actually very excellent. And then what we'll actually see is during this time period, when given adequate ventilatory support, their own surfactant production will generally begin and generally will resolve within 4 to 5 days or so. But prior to this period, you can actually see some pretty significant hypoxemia, especially if they were not treated appropriately. As far as the surfactant goes, this is going to help to hasten the recovery, and also is going to do things like decrease risk of pneumothorax, intraventricular hemorrhage, bronchopulmonary dysplasia, and neonatal mortality. So the way that we're actually going to be treating for respiratory distress syndrome is by utilizing surfactant, as we've said. Two options here include things like Survanta, or Baractant is the generic name. There's also Curosurf or Poractant. You'll notice here that the dose is going to be given via the endotracheal tube. So again, this is not given IV or PO, it's actually instilled directly down the endotracheal tube in order to get directly to the lungs where it's being utilized. Again, you're going to be given this generally for the first 48 hours of life or so in order to help kind of aid the child along while their own surfactant production kind of ramps up. There's a few other options that are out there, but these are just kind of some examples, like Infisurf or Calfactant, and then Surfaxin are other options as well. So the administration of this drug is really unique, and so I'll point this out here that again we're giving this via the endotracheal tube, so basically just instill it right down the tube, and they'll be generally divided each dose into 2 to 4 aliquots. And so generally what happens is with each of these aliquots, they're given between 30 to 60 seconds, and you have to give it to the infant in different positions. So essentially you're going to be kind of rolling the child around, putting them in different positions so that the surfactant can actually get to the different parts of the lungs. Again, if you give it all to the patient in one position, gravity may not be helping you, and you only get it into one spot. So by moving the patient around, you can actually get it to partition into different areas of the lung. You'll actually see that each brand will recommend specific ventilator setting. So again, always check with whatever hospital you're at what their surfactant of choice is, and check those settings prior to administering. And then the other big thing here is to note that because this is a protein-based product, you never want to filter or shake it. Doing that will actually move the proteins out of, it'll actually start to foam up, and that foam has all the denatured proteins in it, so it actually makes the drug less effective. So anytime you have a protein-based product, do not shake it. Now, if we have a child who's having apnea of prematurity, and typically this will be defined as respiratory pauses greater than 20 seconds, we'll see here that the major mechanisms for this happening, or the major mechanisms that the child uses to control their pulmonary ventilation, kind of two features of it. So one being more of a neurological basis found in the brainstem and the cerebral cortex. This is kind of helping to regulate respiratory rate and rhythm. The other factor that kind of goes into regulating ventilation is going to include kind of this chemical sensation, or chemical sensor. So within, especially the carotid and the aortic vessels, they're able to control this alveolar ventilation by changes in the PaCO2. So obviously, as the CO2 were to rise, that would stimulate more respirations. So typically what we see in preterm infants is that their carbon dioxide responsiveness is going to be less developed, and thus even though their CO2 levels are increasing, their body can't really respond to it appropriately. With the classifications here, we can see that the central apnea is really going to be related to those kind of chemical and the neurological factors, we'll see that the breathing efforts are basically going to be absent. On the other hand, though, if we're actually having a physical obstructive apnea, we'll see that the breathing efforts are there, but the obstruction is what's actually preventing the proper respirations from happening. And sometimes it's a little bit of both, so you have like a mixed apnea that can occur as well. Some secondary causes of apnea in neonates can include things like sepsis, intracranial hemorrhage, hypoxemia, temperature instability, and also certain things like congenital anomalies. So if they have like a patent ductus arteriosus, that could be an influencer as well. In order to help prevent apnea prematurity, they recommend avoiding sudden changes in things like temperature, try to preserve nasal patency in order to prevent the obstruction from occurring. In some cases, nasal continuous positive airway pressure, or CPAP, may be necessary. Even things like gentle tactile stimulation, so kind of tapping the bottom of the foot, can help to decrease apnea from occurring. And the big thing we want to focus on, though, is going to be this pharmacological management. So the drug of choice for treating apnea prematurity is one of my favorite drugs of choice for just staying awake, but caffeine is going to be the option here. So caffeine, what it's going to do is actually to stimulate the respiratory drive in the brain itself in order to help increase respiratory rate and depth. And so by doing this, it kind of helps, if the child is having more of a neurological component to it, this can help to stimulate that. It's not necessarily going to fix any kind of obstruction that can occur, but will help to do with the kind of the CNS aspects of it. With caffeine in children, the neonate specifically, it has a very long half-life, so can range anywhere from like 70 to like 230 hours or so. And as you'll remember, the time it takes for a drug to get to steady state is about 4 to 5 half-lives. So if you're thinking, if the kid has a 100-hour half-life, it's going to take 500 hours before it actually gets to a steady state level. So because of that, we actually end up giving caffeine as a loading dose. So we'll give anywhere between 20 to 40 milligrams per kilogram IV or PO. And then you'll actually use a maintenance dosing after that. And so one of the nice benefits here is that even if the patient were to actually miss a dose, or if the drug was discontinued, it has such a long half-life that it actually tapers itself off quite nicely. So there's no kind of like withdrawal apnea that really occurs when caffeine is discontinued. One of the last things we'll talk about is necrotizing enterocolitis, or NEC. This is going to be an inflammatory condition of the bowel that happens primarily in premature infants. Typically there are some intestinal factors that go into this occurring, so typically you'll have some sort of ischemic insult. This will damage the tissue and allow for bacterial colonization, especially when they have a good intraluminal substrate in order to feed off of and actually develop the infection further. Again, risk factors are going to be prematurity, especially less than 34 weeks. Enteral feeding can be related to this. Medications given orally, so all these things can be affecting the GI tract and transit, leading to kind of bacterial involvement there by having such substrate available. Things like circulatory instability and infection can lead to NEC as well, along with impaired mucosal defenses. So basically the presentation is mostly going to be abdominal signs, so we're going to see a lot of distension, gastric retention, tenderness and vomiting, along with diarrhea as well. So all these things will be kind of telltale signs for potentially NEC occurring. Again, you can see here some of the inflamed bowel, the actual perforation that occurred. And so the treatment, while surgery is going to be very important, we'll see that antibiotics are going to be useful as well to eradicate the bacterial infection. So typically what we're going to see utilized is going to be a 3-drug regimen where you utilize a beta-lactam plus an aminoglycoside, and then you'll have a third drug providing some anaerobic coverage. Because again, when you're dealing with the GI tract, you're dealing with an anaerobic environment, and you want to make sure you're dealing with those anaerobic bugs. So typically you'll see something like ampicillin covering your beta-lactams plus gentamicin as your aminoglycoside, and then you can utilize something like either clindamycin or metronidazole, because those both provide very good anaerobic coverage. Typically in my practice I see a lot more metronidazole being utilized for gut coverage of anaerobes. Kind of the general rule of thumb is if it's an infection above the diaphragm, clindamycin's better for anaerobic coverage. If it's below the diaphragm, it's metronidazole. and the duration of treatment is generally going to be between 10 and 14 days. As far as supportive care goes, obviously bowel rest is very important, so you'd be stopping enteral feeds, in which case if you still need to feed the child, then you'd actually utilize something like parenteral nutrition, so utilizing a TPN to provide all the nutrition through the IV. And then of course you'd want to correct any kind of metabolic and hematologic abnormalities that can occur secondary to this massive inflammation. Obviously, surgical interventions will be necessary if there's any kind of perforation that occurs, there's signs of peritonitis, or aspiration of any kind of purulent materials. Obviously, if despite non-surgical support they continue to worsen, then obviously surgery will be indicated here. And really, the goal is to help stabilize the peritoneal infection and preserve as much bowel as possible. But unfortunately, there are cases where you have to resect a lot of the bowel, and then you end up having kids with like kind of short gut syndrome and ostomies that have to be placed. Just as a treatment summary, looking at early onset sepsis, remember that's going to be in the first week or so of life. You want to utilize ampicillin plus gentamicin. Again, the ampicillin is providing listeria coverage. For late onset sepsis, is generally going to be ampicillin or vancomycin. Again, it's going to help cover for things like staph, plus gentamicin or cefotaxime. Cefotaxime being a third generation cephalosporin. For neonatal herpes, acyclovir is going to be the drug of choice. For respiratory distress syndrome, surfactants are going to be utilized. And again, remember how surfactant is administered via the endotracheal tube and via different positions for the patient, being really important. For apnea of prematurity, we see caffeine being our drug of choice here. And then with necrotizing enterocolitis, obviously supportive care with good gut rest, antibiotics for the bacterial infection, and then plus or minus surgery. So, this is the first recorded lecture for the class. Hopefully you guys will find this beneficial. If you have any feedback, please let me know. I know I have a tendency to talk quickly. I try to slow down for you guys' sake, but if you need to, potentially slow it down. Again, we will, at the next class, we will be able to have a couple of minutes just to talk about this section to make sure you guys don't have any questions. But in the meantime, if you do have questions, please write them down and bring them to class on Monday. That way, if other people have the same question, we make sure everyone gets to hear the answer. So, thanks for listening, and I will see you guys next time.